chair and co-chair for the session is Ms. Roli, Singh and Dr. Kirk, Tickell.
I would really like to thank the organizers for having me here for this international conference on maternal and child health nutrition. I'm happy to have as my co-chair Dr. Kirk, Tickell.
Thank you, Chair. And I also would like to thank Sukaria for the opportunity to participate in this conference. I'm here representing the University of Washington, but actually a lot of my work happens in sub-Saharan Africa, particularly in Kenya. So I'm really very excited to learn what I can from your 25 years phenomenal experience here, and to take that back to my partners in Kenya and around the world, and also to learn from the other speakers from across the world. It's a really incredible opportunity. I think I've seen firsthand that actually now what is happening in India in terms of policy is beginning to really inform or is continuing to inform global policy, particularly through WHO and other organizations. So it's very, very exciting to be here to learn firsthand.
Now, one thing that is important to say that though community-based work seems to be, we're just going to go out and speak with communities on nutrition, and we all believe in demystification. Nutrition is not rocket science, but at the same time, you do need to learn it. You do need to learn the basics of nutrition, train one's own self, understand the program schemes and services, and the skills and tools, the soft skills and tools are also extraordinarily important to actually be able to mobilize communities, which is to learn participatory learning, to learn program management, how an MIS works, research and documentation, and these are absolutely critical to achieving that entire spread that I was talking about, all the way from grassroots action to policy work. And if we miss out on any of these, we really remain micro, and it doesn't really scale up to affecting the largeness of the population that needs it. We must choose our strategies wisely. I'll say a few points about that. Plan our community interventions, and then bring learnings to government and larger campaigns for intervening. So in terms of strategy, 2-3 things that I've learned is that we must work on proximal and distal determinants simultaneously. It really doesn't help for us, and there can be unique combinations of that, because the spread is vast. The kind of determinants that we know that we can't work on all determinants simultaneously, but we must still pick different levels of interventions in whatever program that we're choosing to focus on. And so there must be nutrition-specific and nutrition-sensitive combinations. And I also want to add something that I should have put on my slide, that we have been taking a life cycle approach, more and more. So again, the comprehensiveness of working with different age groups. And some of the programs that I'm describing are typically that they intervene in early childhood, they intervene with younger siblings, and they also intervene with women's health and nutrition. So participatory learning and action, just a few words on that, because it has really been a mainstay of all the work that we've done. And I really want to make this point that it is very different from behavior change communication, and it's very, very different from IEC. So I think it's important to understand what those differences are. I don't really have the time to get into it, but just to know that they're not the same thing. And in fact, that difference really converts our approach. It converts the kind of modules we create, the kind of capacity building we do, the kind of mobilization that we do also. And the key principles are, as I said, bottoms up. It really has to be extraordinarily respectful of existing knowledge. It has to be contextually specific, and it has to be therefore adaptive and flexible, but also collaborative. It's not as though community knows everything. When I go in, I'm also taking my expertise as a pediatrician, as a public health person, and I must have that process of dialogue and negotiation with community to be able to arrive at solutions that everybody can have consensus on. Otherwise, it's just not going to go any forward. So that process sounds easy, again, not easy to achieve. Some of the issues that we've taken up, therefore, and again, I've color-coded them to show the spread between the more proximal, more direct, to the more distal. So we will talk about gender, we will talk about rights and entitlements, and we will talk about early marriages and so on, which are very societal, not necessarily very short-term, and what outcomes you may derive out of them. But we will also do very many short-term and direct things on infant and young child feeding, understanding and taking action on growth charts, understanding food and so on, growing your own food, and all that kind of thing. And in between there are the intermediate kind of steps also. So just a brief glimpse of the kind of, we use a lot of, in our country and many of the other spaces where we are really talking to people who are non-schooled and don't have formal learning but have a lot of knowledge. So we use a lot of stories, games, audiovisual.
With regard to adolescence and nutrition, it's important to understand that sustainable healthy diet and eating practices can limit and mitigate the developmental impact of nutritional deficiencies from early childhood. This is a really, really important time to make corrections in those, from those things of early childhood. But it's also important to understand that adolescents come to this understanding of nutrition from a variety of sources. And there are a variety of attitudes that are shaped by these forces, such as familial, cultural and religious preferences, social influences, economic practices, and influences, as well as environmental access. We need to support initiatives aimed at addressing the developmental needs of adolescents, particularly those related to education about healthy nutrition, reproductive and sexual health, especially for females, and promoting health-affirming behaviors and habits that carry into adulthood. And that challenge of sustaining those behaviors into adulthood is really the key here, because this requires consistent support and consistent structural access. We also need to address these socioeconomic drivers of poor nutrition. This includes addressing the influence of advertising for nutritionally deficient foods and beverages, and addressing the social determinants of health that contribute to poor nutrition and developmental outcomes. And finally, but certainly not least, promoting educated and empowered generations of youth. Higher maternal education and employment status reduce the odds of conditions like iron deficiency anemia in children. And developing countries need to continue to adopt policies and programs to sustain girl-child education, maternal education, and economic empowerment of guardians, especially women.
India is completely self-sufficient in eradicating anemia by its own model. In aggregate, there could be a crisis, but look, in aggregate with the tribals, there could be a crisis, because malnutrition outcomes are unfair and anemia outcomes are all unfair. But look into the states. Between NFHS 4 and 5, many states demonstrated reduction in anemia. Can we not learn from those models? Gold mines of models. Look into Sikkim. Between NFHS 3 and NFHS 4, the highest annual average rate of reduction came from Sikkim, which is organic state. And while designing this this Poshan Abhijan anemia target, about 3% reduction per annum, we did calculation from all the states, and based on the average, we decided that 3% reduction per annum is possible, and India has shown that way. So that I wanted to share. There are economic implications. Return on investment on nutrition is very high. If you invest $1 return is 16. It can increase growth, productivity, it can increase human capital potential, because first 1000 days are important. It can increase GDP, it can increase IQ, and many other ways. Looking into the effects of anemia, Sukaria committed to work on health and nutrition, and especially focused on anemia control and anemia reductions. Sukaria malnutrition outcomes are deeply unfair. People like tribals, Dalits, those in difficult hamlets, geographies, they suffer more. So Sukaria always looks into inclusive, community-owned and evidence-based programs, and deeply aligned with vision of the country.
That we must look at nutrition across the life cycle for the woman. Maternal nutrition is special. We need to double down our efforts, but we cannot lose the broader issue of addressing nutrition of girls and women across all the stages of life, including the high-risk phases like pregnancy. We all know about how maternal nutrition directly and in a very critical manner impacts maternal morbidity and mortality reduction, improves maternal well-being, impacts reduction in neonatal and infant morbidity and mortality, and the linkages with underweight and stunting in childhood are also well recognized. We do have a favorable policy landscape in India, but we are struggling with triple burden of maternal undernutrition, a growing burden of overnutrition, and maternal anemia. We need to be delivering the evidence-based package of maternal nutrition interventions integrated within the maternal health services, ANC, postnatal care, and for India, we have both the health and the ICDS system, and we need a combination of system strengthening approaches and SBCC approaches. And while we focus on improving coverage, we cannot miss out on the quality and equity. And these are two main issues which are important for us to achieve desirable improvements in the nutrition outcomes. And
that was pretty detailed.
2018, we launched the Anemia Mukt Bharat program, which takes the life cycle approach and encompasses all the age groups. That is the kind of ownership which the government has for recognizing anemia as a public health issue. Within AMB, most of you must be aware, but just putting it out there, we are looking at the 6x6 strategy. What are the main challenges with, as a government, we are feeling? First, of course, is the poor compliance, which was mentioned earlier also, that there may be distribution of IFA tablets across all age groups. We do know that distribution is taking place, but are the women, are the children, are the adolescents actually eating it, compliance? And then, of course, we all are aware that the absorption of iron depends on a lot of factors, whether it has been taken with food, with vitamin C, empty stomach. So ideally speaking, we do realize IFA should be taken empty stomach for best action. But then if you take it with an empty stomach, it has a lot of gastritis. So that decreases compliance. So do we advise a child to take it with food, without food? That is a kind of I think puzzle a lot of states face, and it ends up coming on us. So also convergence issues, which has come up again with what Sebanti mentioned and also as Vandana has mentioned, is that since anemia beneficiaries are cross-cutting, we cannot have one target program for it. So whether it is women and child development, whether it is education, whether it is health, everybody has to work together. It should not be perceived as a program of health. It is a program of everybody for whom this age group is the beneficiary. So that convergence is a struggle. At a lot of places, we have very good, I think, systems in place at the national level, good ownership of all our ministries. And similar thing has to translate into states, because ultimately health is a state subject. So whatever partnerships, they have to be strengthened, nurtured, and I think re-strengthened again. And the ownership has to be for all the departments who look at these beneficiaries. Next, of course, is the timely procurement. That is an issue with a lot of government schemes. And I think we are honest enough to understand that procurement on time, delivery on time is an issue across all states. Because this distribution, like I mentioned, because it has to reach the last mile. It has to reach the Anganwadi, it has to reach the sub-center, it has to reach all the levels of healthcare institutions. Now even we are having in schools. So distribution to school also has to happen. So it's not just one ministry or one department, it is multiple departments even for distribution. So that takes a lot of, I would say, entwining, meetings. I think a lot of struggle happens there, but that is something which we have to keep working on again and again. Next, of course, is we have capacity building of our healthcare providers, but we need to do it regularly. Next, of course, is the lack of IC, which I agree with what Vandana said. PLA is very important, and in fact, IC is something which with the times changing, especially post-COVID, we have to reinvent a lot of our IC, because during COVID, we have realized that a lot of things have to be digitalized.
Thank you, Zoya.
Now, why nutrition matters? I'm sure you are all familiar with the growth pattern, what happens during the period of pregnancy and what happens during the later parts of the child's life in the first 2 years. Now, if you look at the first, I know it's a very busy slide, pardon me for that, but I thought this is very interesting. If you look at the first trimester, second trimester, and the third trimesters, This is during the pregnancy, and you can see the maternal changes that takes place during the first trimester, second trimester, and the third trimester, and what are the interventions required in terms of supplements. Now, as my co-speakers have been telling, that whether there is a compliance to iron folic acid is a big question, even though it may reach the beneficiaries on time, or it may reach the healthcare providers, but whether the compliance by the beneficiaries is there or not is a big question. In my current study, which I'm currently doing it at Malaysia, and it is amongst the urban poor, which is considered as under B40 group, which is considered as below poverty level, I also found that the non-compliance to iron folic acid is more than 50%. And these are the poor pregnancy outcomes which could be impacted due to the lack of intervention during the appropriate stages, like sickness and immunization and non-adherence, low birth weight, premature birth, difficulties with breastfeeding, difficulty in bonding with the mothers, crying and irritability, abandonment, abuse or neglect, mental health and conduct problems, and many others. What's the impact of poor maternal nutrition on the child during the first 1000 days of life? We know that it plays a foundational role in the child's development, not only on the mother but also on the child's future development, causes irreversible damage to the child's growing brain, affects the child's ability to do well in school cognitively, makes it harder for a child and her family to rise out of poverty, and sets the stage for a lifetime of health problems. So the key takeaways from this presentation, specifically on the mother's nutrition status, is 1000 days is of immense importance, be it for the child or for the mother, but it starts with the mother's nutritional status, as the mother undergoes many physiological changes during pregnancy. So the way forward could be a systematic follow-up of nutritional status of both mothers and children up to 2 years of age. That could help us to identify the gaps and intervene accordingly. Provide education on sustainable nutrition and a positive behavior change, not only amongst the mothers but also with the spouse, because the family should be taken as an entity and mother alone should not be given the responsibility of bringing up her child on her own. And identify the barriers of food availability, accessibility and affordability for ensuring food security.
So that was a very comprehensive study that you presented here today.
The women with moderate or severe anemia during the second and the third trimester of pregnancy are often unable to make up in the third trimester. So definitely there will be an impact on the growing child. Despite of an acute transport via placenta, insufficient iron may be transmitted to the developing fetus, leading to the long-term neurodevelopmental sequelae. The studies have shown that the oral iron may not be having an optimally reach the placenta and to the fetus. So oral iron has this limitation. So because of that, there are also a published evidence suggests that iron deficiency in infancy may cause cognitive and behavior abnormalities, and this is proved beyond the doubt. So we are trying to address these challenges and how this can be minimized. So what we hypothesized is that a singleton pregnant mother with a moderate anemia who has randomly assigned to the IV iron arm and receives early in the second trimester, that is between 13 to 17 weeks of her gestation, a single dose of iron molecule for the treatment of iron deficiency anemia, which is currently recommended, and along with that currently recommended daily doses of folic acid, will have the higher conversion rate to non-anemic status in last trimester of pregnancy at 30 to 34 weeks antenatal visit or prior to delivery than pregnant woman assigned to the oral iron arm. So we are seeing that the improvement in the hemoglobin at the third trimester at the time of the delivery, that's our primary outcome by doing a single intervention of IV iron infusion. So the second hypothesis was the pregnant participant assigned to the IV iron arm treatment group will have the lower rate of low birth weight babies. Less than 20% relative reduction will be seen. That was what we are hypothesized, and based on that we are doing the study. So what intervention we did is the women are assigned to 3 arms. 2 arms will get the IV iron molecule. 1 molecule is a FCM, that's also single dose in the early second trimester. Second is iron isomaltoside. And along with the control arm, we have taken here as an oral arm group, where the control arm, as per our AMB, 60 milligrams of elemental iron is given to them along with that of the folic acid, and folic acid is given also to the IV iron group. And along with that, deworming is given to both the groups. So the inclusion criteria, as we know, that means the women who are between 18 to 40 and who are giving the informed consent, and specifically we are also looking into that the woman should be staying in and around that place, so that we would be able to follow her up 6 times post intervention, and along with that, at the time of delivery we are able to collect her cord blood and also pre-delivery sample, and also to follow her up to 42 days. For that we made inclusion criteria that the woman should be residing in that in and around area. And one thing is, women should be willing to participate in this trial, because
Thank you so much. Those were all really wonderful talks, and I think they were very hopeful talks in that we've seen across many states in India it is possible to make these changes, and that's something that can be replicated globally. And we've seen so many different types of interventions, from the proximal to the distal, in different groups, adolescents and mothers and young children as well. I think it's all just incredibly hopeful. I thought some of the barriers that were brought up around the multi-sectoral approach and issues with compliance were very important. And I think one other barrier that perhaps we've not spoken about is garnering the political will from donors and convincing policymakers to help us maintain these interventions that have been so successful. And so I think we're very fortunate today to have policymakers with us, policymakers who are allies in this fight. And so perhaps you can continue to teach us how to sell and advocate for these programs and these interventions for the next 25 years. Thank you.
It will be very difficult to sum up, because that is one of the things the chair should be doing. But I think we've seen different standpoints and different points of view based on the the profile of our speakers. And I think it's been a very interesting and a very educative experience for me personally. I mean, I would have liked to be sitting on that side and asking some questions myself. But the thing that I can just say is that, most of the things are covered. We know that it has to be a life cycle approach. We know that it has to be working with communities. Government policies need to be informed by the findings or the learnings that you people have shared here today. But as you can see, India, I mean, if I strictly speak from India's point of view, we are a very huge, complex country. When we talk about dietary intake, I mean, it just varies. Every 100 kilometers, there'll be a different way of eating, different way of, understanding around food. And it's very difficult to have a one-size-fit-all kind of a narrative for this sector. And wherever you go, you'll find so many mindsets and views about what is to be eaten, when it is to be eaten, especially when it comes to pregnant women. What should children be fed? Though the government is trying to say one thing, the local wisdom says another. So it's a huge challenge, and that's why we need partners who have worked in the field, who can understand the context and who can contextualize. As Dr. Prasad spoke, I was very, very enthused to see the kind of work that you've done in the field, and the way, especially dealing with tribal women, and looked at their context. And I think the idea of PLA and IEC and SBCC that you brought about resonates with me completely, because IEC is obviously very top-driven kind of a thing, and SBCC is about behavior change of the people you are addressing it to. But there has to be a lot of behavior change for the people who are actually delivering these programs in the field as well, because they come from the same socio-economic backgrounds, or the same, especially our field level functionaries who are such key persons in addressing these issues at the community level, our Anganwadis and our Ashas. And convergence across departments is another thing that we have been talking about and have been struggling with. But happily speaking, I would say happily, the state governments, many state governments who have cracked this conundrum are the ones who are working well in tandem with each other, where the ICDS and the health and the education have somewhat converged, and they have realized how to crack the implementation challenge. And at this center, we still talk about, especially in adolescent health, when Zoya was working on that subject, and we were constantly looking at ways of, working with school education and working with our Anganwadis on the issue of tackling adolescent mental health issues, be it menstrual health and all kinds of things. So challenges are huge, but there's a lot of learning, and I'm sure these 2 days are going to help you, come up with some policy suggestions, some way forwards for the government to look at. I would not say that, it's rocket science again or something new, but yes, something that can be broken down into, what can be implemented immediately, what needs to be looked at from the macro perspective. Are we doing it right when we are looking at only iron folic supplements? So that study that Dr. Umesh talked about would be very, very, I think, informative, and I think it would be a groundbreaking kind of a study if it comes out, in a positive sense. Thanks a lot.